This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, let's see a case of pathological myopia. And what are the challenges which we face when you're trying to perform phacoemulsification in these eyes? Now, she's a 60-year-old lady who has come for cataract surgery, and A scan shows her IOL power to be around -3 diopters. I'm just sharing with you the clips of the A scan biometry. You can see this is the axial length, and of course the chamber would be very deep in these eyes. So first, the lens selection choice. In such eyes, I usually take an average of the Sarketi and the Barrett's formula and then choose the lens. And usually the aim is to leave a residual refractive error of about -0.5 to -1. Her macula is reasonably healthy. And so before doing the surgery, let me just point out few intraoperative concerns which we might have in these patients. The first and probably the most important concern is to have an adequately sized and well-centered rhexis. That's a challenge because the pupils will be so much well dilating in these eyes, and we may get an rhexis which would be slightly bigger than what it would be ideal. So that's a challenge, first to size it well and also to center it. Now, because the pupil is so well dilated, and usually we use the iris as a reference to size the rhexis, it's going to be a challenge in this case. So I'm going to use a corneal marker, which gives an impression of about 5 mm on the cornea, and I'm going to base my rhexis on this corneal mark. I ask the patient to look straight into the light, and I'm trying to leave an indentation mark on the cornea. I get the mark, but I think it's slightly eccentric, and which I have noticed intraoperatively, but the goal is to try to be within this ring as I complete my rhexis. So I'm using a forceps to perform the rhexis. The rhexis is begun and the tear is continued. The zonules are very healthy and the rhexis is not at all a problem, but I suspect it's slightly off-center. Although the sizing is okay, I suspect it is a little bit off-center. So time to perform the hydrodissection. The cannula is introduced under the anticapsule. The capsule is tipped up a little bit and a gentle wave of fluid is passed across, and we can see the fluid wave going across the posterior part of the lens. The nucleus is tapped on the opposite quadrant to let out the fluid. So once the bag is decompressed, OVD is put into the eye, the nucleus rotation is confirmed, time to phaco. The superficial epinucleus in cortex is removed. Time to chop. So the nucleus is quite soft, so I've kept the longitudinal power of just 20. I'm just trying to engage and use a sort of a mixture of a horizontal and vertical chop. The chopper is placed much more beyond the tip, and as the chopper comes down and towards the phaco tip, and then the lateral separation maneuvers are being done, I realize that the hold is pretty weak, but nevertheless I could get some amount of crack in this soft nucleus. The nucleus is rotated and then the second chop is being done. Again, you can see that the nucleus is just melting and literally there is no hold. So I asked my assistant to reduce the power still to 20. So we've got 3 fragments, and then in quadrant removal mode, I just take out all these fragments. So usually in these high myopes, we have something called as the lens iris diaphragm retropulsion syndrome or the reverse pupil block. So in this case, it was not very obvious. So a couple of ways to deal with it would be to, before you start the infusion, lift up the iris with the second instrument before you start the infusion. And second would be start with a low bottle height and then gradually increase. These lens iris retropulsion syndrome I have experienced more in relatively younger patients compared to older patients, probably because of the lesser scleral rigidity as well. In this case, anyway, that was not very obvious. So the second heminucleus is then emulsified in a very quick manner. The nucleus management was relatively easy as it was quite soft. The time to aspirate the cortex is not much, and it's quickly stripped off. And now we have certain small fibers sticking out of the posterior capsule. And let me try to flush this out with the BSS using a 5 ml syringe. Now, because this is a myopic eye, usually we have got excellent red glow, and this good red glow ensures that we see each of these fibers pretty well sticking onto the posterior capsule, and they are carefully but surely polished out using the jet of BSS through this cannula. Hydropolishing is a relatively quick way of cleaning up the posterior capsule, and I always prefer to do it through the main incision itself. The capsule looks to be clean, so now is the time to implant the lens. In these extreme eyes with pathological myopia, I usually prefer to put in a CTR, which is bigger. This would be around 12 to 14 millimeter diameter. The idea of using the CTR is to ensure that once the equator of the capsular bag is stretched because of the CTR, the chances of the posterior capsule sticking onto the optic of the lens is much more higher. And if it sticks on earlier and quicker, then the chances of PCO formation would be much less. So that is my idea of using a CTR. Only thing one need to be mindful is that you use a CTR which is slightly larger than what would you use for a routine eye, because these eyes, the capsular bag itself would be quite huge. The -3 diopter lens, which is available only in the multi-piece format, and this is from Alcon in the Expand series. The lens is gently maneuvered into the bag. OVD both in front and behind the lens is aspirated out. The side ports are hydrated well. That's it, the case is done. As was my suspicion, the rhexis is slightly eccentric at one part, but it should be fine. So the message is, getting the rhexis well centered and appropriately sized is the biggest challenge when you're dealing with these large eyes. So that was it. Thank you for watching and hope you found this helpful.